welcome back, everyone. We're gonna have a good lunch. And letting the insulin hit their system, and as blood sugars drop, eyes get heavier, begin to close. Yes. All right. Any questions from the first section of the cardio stuff? I put in an announcement. Did you guys re-download this lecture? I added one slide. Apologize for forgetting that, but just make sure 51 slides, I believe, is the correct number there. All right. So we're going to talk more about action potentials. Everyone remember those? Or did you already dump that knowledge? Don't dump it. Keep it forever, please. It'll be good for talking about this and many other classes, as we'll see. And then we'll talk about some of the more cardiac function, some of the vascular regulatory systems, etc. And talk about a little bit about EKGs. You may say, you're a pharmacist. What are you doing teaching EKGs? I will even show you why, as a toxicologist, I do need to at least know something about EKGs. And we'll go over the basics here. And then you'll have a whole class with Professor Q. You'll go over all of that in much more detail. But at least go over some of the basics here. All right. When I say cardiac cycle, what does that mean? Anyone know? Yeah, essentially, it's kind of the contractions, the cycles that occur as far as like how things are contracting in a sequence that allows for efficient blood flow out of the heart, right? So blood flow going into the heart and then out of the heart. And so things need to work in a good natural order. Because again, when the heart squeezes, does all the muscle contract all at the same time? No, it wouldn't be very good. It wouldn't be very efficient. We're going to see it needs to undergo a certain sequence of events that occur. And we'll cover those in more detail to make sure we're pumping blood very efficiently here, right? Cover the different structures of the heart. So we remember that blood's coming into which side of the heart? From the venous side on the right side, right? And then it goes into where? Right atria to right ventricle to good. Yeah, so again, through the pulmonary valve, and it's going to go to the lungs essentially, and it's going to go back to the left atria, left ventricle, aorta, and then out to wherever else it's going to go, right? So we talked about that. Everyone's pretty familiar with that process, and that's good. So anyway, so we mentioned that cardiac cycles, that repeating contraction and relaxation of the heart. And so we talked about systole and diastole in some detail here. So systole meaning what? The squeeze, the contraction of the heart. Certainly there's going to be a ventricular systole and then an atrial systole. Those are going to be different processes occurring there. However, when we think of like kind of systole in general, what are we thinking of? The ventricles, right? Because those are the main mover. That's the main mover and shaker of the heart, essentially, right? It's kind of pumping all that blood outside of it. So it's going to be the big thing there. So, and then diastole is going to be the relaxation of the different chambers there. Obviously, there's going to be an atrial and a ventricular diastole. When we say, diastolic blood pressure, so we're basically referring to as that ventricular relaxation, though. So again, that's mainly what we're saying. Systole and diastole in kind of more broad senses. We're thinking of the ventricles essentially. Okay, a couple of terms we'll talk about here. So we have things like in systolic volume. Anyone know what that is? Yeah, so basically when the ventricle, yeah, thank you for saying the obvious, but that is quite correct. So at the end of the actual squeeze of the ventricle, it's kind of what's the volume of blood that's left over there, right? So again, should that be 0? No, right? So again, when you get into different disease states, we'll talk about different disease processes that can actually modify this. But what you'll find, there should be some volume left over, so that's going to be the end systolic volume, and then the end diastolic volume would be what? At the end of diastole, the end of relaxation of the ventricle is kind of what volume is there as well. And so you can kind of figure out things like, ejection fraction. Anyone ever heard of that term before? Right, that kind of tells you kind of what fraction of blood that is in the ventricles actually gets, ejected from there into the aorta. That's going to be important because when you have things like left ventricular dysfunction, that's going to be making the left side of the heart pump less efficiently. And what does you think that does to you, like your ejection fraction? Tends to decrease it, right? So again, you may find that the heart's being less and less efficient, you're pumping less and less blood out. And then next section, we'll talk about preload and afterload and all that. Those are terms you guys have heard before. We'll go into more detail and talk about ways we can affect that. But right now, we're just talking specifically about the actual cardiac cycle, and then the next time we'll talk about more like blood pressure control and all of that. So, again, we just kind of went through this, and everyone has a pretty good idea of kind of the cardiac cycle, where blood's flowing to, where it's going to. We're going to be getting into kind of more specifics of especially on the electrical side of things, like how that's actually occurring, how to make sure we have a good, kind of synchronous sort of contraction of the atria, synchronous contraction of the ventricles to make sure blood's flowing efficiently. We're going to get more detail on that. So that's where like action potentials are going to come back through. We'll talk about pacemaker cells. We're going to talk about EKG and how we actually pick up that electrical activity and how we can determine whether it's normal, abnormal, etc. So, and then when you're looking at the cardiac cycle, you can see here the systole is, a fairly short period of time. The ventricles are actually contracting. Right, let me get the laser pointer. So this is where you're going to be finding the ventricles are contracting. Normally when the ventricles are squeezing, the atria should be doing what? Typically relaxing, right? And then over here on the diastole side is when you're going to have the ventricles relaxing. Because again, when these chambers are relaxed, what can they do? They can fill up with blood essentially, right? So again, when they're squeezing, they're trying to eject blood, but they need to relax in order to accept that. And again, that's important. We're talking about things that are remodeling of the left ventricle. And again, I say remodeling. It's not like moving the sofa to the other side of the atria or something like that. When we're talking about left ventricular remodeling, it's talking about the tissue, actual organization of the tissue itself, and what type of tissue is there. And you can find that things like, the left ventricle becomes more stiff in some disease states, and it makes it so that you have a harder time of relaxing the ventricle and less blood can actually flow in. Different things like that can occur. But towards the end here is where we're going to see the atria contract. And this is again where when the atria contract, what's that going to do? Cause blood to go into the, all right, so again, this is kind of occurring over this whole period here. But again, one of the things to note here is notice kind of the fractions of time that you're in systole versus diastole. This is kind of important because when you're looking at blood pressure, normally it's kind of two numbers. What's the top number? Systolic blood pressure, and then you have your diastolic blood pressure. Has anyone ever heard of mean arterial pressure? Yeah, how do you get that number? Because you can measure it with a catheter potentially. With a good way you can do it with math. The power of math. Well, basically what you do, you don't add them together and divide by 2, because again, the heart is not in systole half of the time, and diastole half the time. Roughly a third of the time you're in systole, and then 2/3 of the time you're in diastole. So actually, when you're calculating mean arterial pressure, you can just take 1/3 of the systolic blood pressure and divide it by 2/3, or add it to 2/3 of the diastolic. By adding those two numbers together, you get a mean pressure, right? Because again, that basically is what you're getting is the mean value there, and that can be useful because oftentimes, like when you're, at least when I'm dealing with it from a drug standpoint, say we're giving a drug that is trying to maintain a certain blood pressure. Oftentimes the instructions are maintain, say, a mean arterial pressure of 65, right? And so by getting that number, that's how you can determine kind of where you're at as far as like the mean value of that pressure. Again, a little bit of a tangent, but this will come up again later on in other courses. Does that make sense? So again, about a third of the time you're in systole, 2/3 of the time roughly you're in diastole. Okay. Okay, so again, when we say ventricular systole, kind of broadly, you can refer to this as just systole in general. What's happening here is we're going to be having the atria relaxing, right? So again, this would be atrial diastole is occurring here during a ventricular systole. And then this is where we're going to have the AV valves closing. This is the lub sound. This is also known as S1, right? So again, this is when you have the ventricles contracting, right? And that pressure that builds up in there does what to, like, say, the mitral valve? Going to cause it to close, right? So again, that increasing pressure in the ventricles will cause those the AV valves to close at that point, and then the ventricles contract, and that's going to cause the blood to. And what happens like the semilunar valves at that point? Yeah, the pressure builds up, and that's going to cause those to open up, and then you're going to have blood actually flowing out, right? So that's what's happening during the actual the ventricular systole right there. Now, when this occurred and you had the ventricles actually beginning to contract, you're going to notice that there's a period of time where the semilunar valves are still closed. The pressure is enough to where it's going to close the mitral valve. The semilunar valves are still going to be closed at this point. You notice here that the pressure builds even though the volume of blood doesn't really change. And so in that case there, what we actually have is called the isovolumic contraction. And I'll show you this graph here in a minute that makes it a little bit more clear. But we're going to be referring back to this in a second. But basically when you have no change in volume but the pressure is continuing to increase, it's called isovolumic contraction. So the pressure is building, and then as the pressure builds, those semilunar valves then open up, and that's going to allow for the blood to be ejected out into either the pulmonary arteries or over into the aorta. Okay, so that's an important period there where the pressure is building, both sets of valves are closed, and then all of a sudden the pressure hits a certain tipping point, and then boom, semilunar valves are open. Okay. Then obviously the opposite is going to occur during diastole. So this is when the ventricles are going to relax. You're going to notice this is when S2 occurs, right? So this is when the semilunar valves are going to be closing. At this point, what causes the semilunar valves to close in those cases? Like say for instance, like with the aorta and the left ventricle. The decreasing pressure in the ventricle, the pressure is higher at that point. The aortic pressure is higher, right? So again, the aortic pressure is going to be higher, and that forces the semilunar valve closed, right? Make sense? So again, ventricle pressure is decreasing, pressure is higher in the aorta, that's going to cause the semilunar valves to close. That's how we prevent that backflow of blood back into the ventricle at that point, right? So we're going to have the AV valves are going to start to open up now because now the pressure is dropping in the ventricle as it starts to relax. That's going to allow for blood to flow passively into the ventricles at that point, right? So again, the way the blood's getting into the ventricles, not just with atrial squeeze, that's going to happen towards the end there, but just by the ventricles relaxing, that opens up the AV valves. That's going to allow blood to flow passively, usually according to gravity, because most of us are sitting upright most of the time, and that will then eventually you'll have atrial systole occur, and that will force kind of the last amount of blood into the ventricle there. All right, so again, as the pressure in the ventricles falls, that causes the semilunar valves to close. Again, that's S2 that occurs there. And again, at this point, before the AV valves open up, that's what we call the isoclinic relaxation, right? So again, no change in actual blood volumes occurring at that point. You're still roughly at that in-systolic volume. That as that pressure starts to decrease even further, that's when the AV valves are going to open up, and that's where the blood starts to flow in. Eventually, you're going to have the atrial systole that forces that last amount of blood back into the ventricles. Okay. All right, so I think this graph does a pretty good job. It's pretty busy, but I think if you kind of suss it out into its individual points here, we'll kind of it'll make a little bit more sense with it, right? So again, things we're going to mainly be focusing on here is looking at atrial pressure. We're looking at ventricular pressure, which is this red line here, and then we're also going to be looking at the ventricular volume. You can see your heart sounds here. Usually S1 and S2 are the big ones we're going to be focusing on, and then you'll also notice your EKG strip down here. We're going to go into more detail on this a little bit later on. I'm sure some of you have at least a little bit of passing information about this, but we'll always get into the basics of it. So, what's occurring here? So, say for instance, we're going to have, excuse me. All right, right here we're going to have the AV valves are going to be closing at this point. So imagine we're about to have our ventricular systole occur here, right? So we're getting ready for ventricular systole. Our AV valves are now closed because the ventricles are starting to contract. So you start to see that pressure build up a little bit. At this point, the semilunar valves are what? They're open or closed. So again, we're getting ready for ventricular systole. So those SL valves should be closed at this point, right? Because again, that's how we have that isovolumic contraction occur. Okay. So again, as you have the ventricular volume, the actual pressure start to increase. Notice here the actual volume doesn't change, right? Because then we've already had the atria start to squeeze. Already had atrial systole. We're now having the ventricular systole before the SL valves pop open. That's that isovolumic contraction that occurs there. And again, this is a brief period of time because once the pressure gets high enough, notice here the aortic valve now opens. Okay. Again, aortic valve is one of the semilunar valves that's going to pop open, and then this is where you actually have the ejection here. And what do you notice about the aortic pressure? Notice how it kind of perks up here as well, because again, that's all the ventricular pressure kind of opening up that valve, and all of it is kind of flowing out very forcefully, right? So again, as you start to have that pressure start to decrease, this is where you're going to find that the semilunar valves are going to close first, right? And at this point, again, that's which heart sound at this point? Notice S2, right? So you can kind of see it starting to line up here. At this point, this is before the mitral valve has opened up. You're going to have that isovolumic relaxation. You notice again here the volume doesn't really change much. And then you're going to find that the AV valve is going to open up at this point. And so notice you're going to have a big volume increase in the ventricles. And this is before the atria even contract, right? This is all just to gravity essentially. And all that blood's going to flow in. And then at this point here is where you're going to have atrial systole. That's going to kind of force the last amount of blood into the ventricles. And that's then going to cause, trigger off, going to be the ventricular systole again. Does that kind of make sense? Right, so again, keep in mind like where the valves are opening and closing, where blood's going, how the pressure is building up or decreasing, and what effects that's going to have. Okay, and again, just go back to this and kind of see how everything is kind of lining up. Know where the S1 is, know where the S2 is, and all that, how it's lining up with which kind of physiologic events are actually occurring right there within the heart. Okay. Everyone with me? All right, like I said, it's busy, but I think overall, when you kind of get used to looking at it, it makes a little bit more sense and it can be kind of useful. Okay, so how do we actually make all of that work? How do we actually cause the heart to beat as we want it to without causing any kind of arrhythmia to occur? What's kind of the natural order of things? And so we'll talk about the electrical activity here of the heart and how it correlates to the EKG. Okay, so what are some ways we can actually affect the heart as far as the speed of the heart, the contractility, the rate at which we're having relaxation? All these different things can be affected, and two of the big things it does is going to be our parasympathetic and our sympathetic nervous system. Again, we're going to talk more about this in detail kind of broadly towards the end of the class, but we'll talk about it here from the cardio aspects first. And so if you had to guess, what is it you think your parasympathetic nervous system, which is releasing acetylcholine onto these muscarinic receptors, what do you think it does to the heart? Probably slows it down, right? Because again, this is a rest and digest sort of nervous system as we're kind of getting relaxed. You guys probably have a lot of parasympathetic activity going on right now. You just ate lunch, trying to digest your food. Your heart rate, you're probably sitting kind of low, right? On the flip side of that, we have our sympathetic nervous system. kind of kicks up into high gear. What is that going to do to heart rate? Tends to increase it, right? And you're going to see this is actually, you can see very clearly when you see kind of the direct innervation of the parasympathetic and sympathetic nervous system in the heart here. So two of the big things that it's going to be affecting are going to be our SA node and the AV node. You know what these nodes are good for? Yeah, this is basically where the action potentials are starting, right? So again, what's another name for these type of cells? Anyone know? These are going to be our pacemaker cells, right? So again, these are also going to be called slow response cells, as we'll see in just a few minutes. But these are going to be our pacemaker cells, right? These are setting the pace for the heart. You're going to find that in general, the SA node is going to be kind of the predominant one for most patients, followed by the AV node. And typically, all of your pacemaker cells kind of fall under a certain hierarchy, where the SA node kind of takes the lead, because normally it has the fastest rate associated with it. Okay, AV node's kind of subservient to that. However, you can see in some patients, if they were to have, say, their SA node damaged or say removed or ablated for some reason, you can find that the AV node would take over, right? And we'll see some of the intrinsic rates associated with that and why they are considered pacemaker cells, what kind of makes them that way. But a lot of it is going to go right back to the action potential, as we'll see in a little bit. But just know the SA node and AV node, these are two of the big places where we're actually going to control heart rate. Okay, and you can see here that the vagus nerve. Anyone remember which cranial nerve that is? 10, good. That's going to be mainly our parasympathetic nerve here. Notice it's going to have a direct innervation here, both the SA and the AV node. And remember, that's releasing acetylcholine. Notice it's going to be affecting that muscarinic receptors. It's going to work to slow down the heart, essentially. Okay. On the flip side of that, we're going to have the sympathetic nerves here coming from these sympathetic ganglion here, kind of lying lateral to the spinal cord on either side. You're going to see that's going to be directly innervating both the SA and the AV nodes. It's also going to be directing areas of the ventricle as well. So we're going to see that and anyone remember what neurotransmitters being released for the sympathetic nervous system? Like epi, norepi, mostly like norepi in these cases here. So you're going to see norepi is going to be a big player. Again, this can also be affected by circulating catecholamines as well. Like, epinephrine being released from the adrenal gland can still affect the heart. Similarly, it's just you don't have that kind of direct innervation. This is the sort of thing where if I were to call on one of you to come up and sing a song or something, and your sympathetic nervous system's kicking in really fast, this would be the thing that is going to get your heart rate going the quickest, right? The adrenal gland is going to take a little bit to kind of catch up because it relies on the bloodstream and all. That's a little bit slower. Okay, so looking at the pacemaker cells in the SA node, because again, it's going to be the first one we're talking about, because again, it's kind of the king as far as pacemaker cells go, and it being kind of the one that sets the rate for the heart, essentially. What you're going to find is that we can modulate pretty drastically what your heart rate's going to be. So for instance, if I have a lot of, say sympathetic innervation, how fast can your heart go, essentially? What's like a normal fast heart rate? Yeah, I guess that's a really bad question. What would you consider to be a fast heart rate? Anything over 100, right? What do you call that? Tachycardia, right? So tachycardia, we'll talk about that. So again, that's usually going to be caused by the sympathetic nervous system, right? On the flip side, what would you consider to be bradycardia? Yeah, anything less than 60, right? So again, now is anything less than 60 abnormal necessarily? Not necessarily. If you have a really athletic person, you can find they're sitting in the 50s, no problem. Just depends on the patient. So again, normal is always going to be a little bit different depending on the clinical situation. But you can find that these are the main receptors that we're going to be interacting with that have big effects here. So mainly what you're going to find from the vagus nerve and the parasympathetic nervous system is that this is releasing acetylcholine onto these muscarinic receptors. I don't care that it's an M2 specifically. I will want you to know the difference between beta 1 and beta 2 because that'll be more clinically important as we go forward. But just know that for the parasympathetic, it's going to be going through the vagus nerve that's releasing acetylcholine onto a muscarinic receptor, and it's generally going to have inhibitory properties on the heart. It's going to generally slow things down for the most part. Now, when I say chronotropy, anyone know what that means? That's actually the heart rate itself, right? So again, if I have a positive chronotrope, that's going to increase heart rate. If I had a negative chronotrope, that would slow down the heart rate. So it's just the rate itself, okay? One thing. Anyone know what dromotropy is? So this is another one. We don't talk about this quite as much. Normally when you think about the heart, you're talking about chronotropy and inotropy. This isn't one term that is still used occasionally. Dromotropy is basically going to be the speed of conduction of electricity through the heart. So if you hear a positive dromotrope, that would be something that increases that speed of conduction, essentially. Okay. Inotropy. Anyone know what inotropy is? The contractility. So that's actually the strength of the squeeze on the heart. Okay. So I have a positive inotrope that would cause the heart to squeeze harder. What do you think that would do to the amount of blood you're sending out of the heart? And squeezing harder should cause more blood to go out, right? So when we talk about cardiac output in the next section, we're going to see this is going to be a positive thing. It's going to increase the amount of blood you're sending out with each squeeze, essentially, right? So again, two of the main ways you can affect cardiac output with the heart specifically is how fast it's beating and how strong it's beating, right? So how strong that contractility is. So inotropy is the contractility, how strong the squeeze is. Okay. Yes, sir.
You said dromotropy relates to the action potentials itself?
Basically, the speed of the conduction. So like how we'll actually see the electricity, how fast it travels, is going to be related back to the dromotropy, essentially. And clinically, the two big ones you're going to talk about most frequently is chronotropy and inotropy, right? So if you're talking about a CHF patient, you're talking about inotropes or positive inotropes. These are things you kind of will hear talked about more frequently. And then lusotropy or lusotropy. Anyone familiar with that one? That's kind of the speed of relaxation of the heart, essentially. Again, this one I hardly ever hear clinically ever being used, but that would be another term for that. Okay. So, so again, acetylcholine on these muscarinic receptors, bless you, will typically have a negative effect. So it should slow down heart rate. It should kind of have a modestly negative effect on contractility. That should the squeeze of the heart should go down a little bit. The main thing you're going to see with the muscarinic receptors is mainly going to slow down the heart, right? So mainly going to be slowing down that heart rate. Usually, you find bradycardia being a very common thing. You'll see with that. On the other hand, with the sympathetic nerves, norepinephrine is going to be the big neurotransmitter here being released from these nerves, and you're going to find that the two main beta receptors we have, there's also a third one, we're not going to talk about it here, but there's beta 1 and beta 2. The predominant one on the heart is going to be beta 1. Okay, so beta 1 is going to be the main thing norepinephrine is interacting with. The cause is positive chronotropy, inotropy, dromotropy, this lusotropy. You're going to find that norepinephrine has a very positive effect on all four of these aspects. Okay, so again, if I said, a patient were to have, say, for instance, a beta blocker, so say something came on and was blocking those beta receptors, what do you think that effect would have on the heart? Yeah, it would slow it down, essentially, right? And that kind of makes sense based on what we were talking about before, like, propranolol being a beta blocker and it slows down your heart rate. That's why it's good for, like, performance anxiety when your sympathetic nervous system is normally really ramped up. Those beta 1 receptors are just being hammered on by all that norepi. I can block that up, all of a sudden the heart rate starts to come down. Similarly, what if I blocked those muscarinic receptors? What do you think that would do? Should increase heart rate, right? Anyone know of a really common antimuscarinic we use on the heart? Speed up atropine, yeah. So if you work with like EMS at all or in emergency medicine, use atropine. If you have a patient who's bradycardic, the heart rate's too slow, what I can actually do is either I could give them something like norepi to help increase the heart rate, or I can give them something to block that acetylcholine receptor. And that by blocking that, you can actually cause the heart rate to speed up pretty dramatically, right? So again, something may run into. Again, you don't have to know these drug examples. I'm just trying to show you how we can modify the normal physiology to our whim, essentially, to try to kind of fix whatever is actually wrong with the patient, essentially. Okay. So question is, well, how does it do that? How does it actually modify the heart rate? How does it actually change all that? Well, a lot of it goes back to changing the resting membrane potential, right? So we said when you go back to looking at like a normal resting membrane, in the heart, you may be sitting at something like -55, -60, because remember, our cells are typically going to be more negative on the inside than on the outside. That's why they have a negative resting membrane potential. However, I can modify that. If I were to say make it more negative, what do you think that would do to the ability for it to generate an action potential? It's going to be harder, right? Because you're kind of starting out more in debt than you were to begin with. If you kind of think about it like that, the more negative you are, the harder it's going to be to have an action potential. Okay. However, if I were to modify to maybe increase the resting membrane potential, make it more positive, what do you think that would do? It'd be easier or harder to have an action potential? Be easier, right? So again, I'd be more likely to have an action potential. So again, that would make the heart rate go faster, as you will see. And I'll show you what this looks like with some of these pacemaker cells a little bit later. But the main way we're going to do that is by modifying these potassium channels. Okay, so remember, potassium levels are particularly high in the cell or high on the outside of the cell. On the inside of the cell, remember, because again, salt wrapped banana analogy, right? Your sodium's a lot higher on the outside of the cell, potassium's a lot higher on the inside of the cell. So if I were to say open up potassium channels, say, for instance, I have acetylcholine come along, activate a muscarinic receptor, and I open those potassium channels. Potassium is going to flow in which direction? It's going to flow out of the cell. And what do you think that would do to the potential of the resting membrane? It's going to make it more negative because I'm losing positive ions, right? I'm losing those cations out of the, going through those channels. You're going to find that it's going to draw the resting membrane potential more negative, and it's going to make it more difficult to have an action potential. So I'm slowing down the heart rate, essentially. Okay. I'll show you what that looks like in some of these graphs here in a few minutes. Okay. On the flip side of that, you can have opposite effects with like something like a sympathetic nerve, where basically epinephrine, norepi can actually increase the heart rate. And in these cases, it would do something like opening up sodium channels. So we said sodium's higher on the outside of the cell. If I open up sodium channels, what is that going to do to the resting membrane potential? It's going to make it more positive. It's going to increase it, and then now it's easier to have an action potential. Also, we're going to find calcium is really important here for causing heart contraction. We're going to see that's going to be a big player too with some of these pacemaker cells. Okay, that makes sense. Again, beta 1 receptor is the predominant thing going to be in the heart. When we're thinking about beta 2 receptors, we're going to say that's going to be a big player in the lungs, but beta 1 is the predominant thing in the heart. Okay, all right. So kind of showing you the differences here between, kind of like maximum like sympathetic stimulation versus parasympathetic stimulation. You're going to see cardiac output. Usually it's going to be measured as liters per minute. And you're going to see here, imagine you had, say 0, or say like normal sympathetic stimulation here. So again, looking at the cardiac output, it's right around, let's say, 13 or so. If I were to have increased sympathetic activation, say, a bear popped out and is about to attack me, I would have pretty maximum sympathetic stimulation. So you can have a pretty big increase in cardiac output, right? Because again, not only is the heart beating faster, it's also beating what? It's also being stronger as well, right? So again, not only am I getting having more contractions, pumping more blood out, but the amount of blood I'm pumping out with each contraction actually goes up as well. So there's kind of 2 components there that are going to be increasing that cardiac output. And we're going to go over that in more detail in the next section. But and then if you were to have, say, like 0 sympathetic stimulation, you notice here it would go down somewhat, and then parasympathetic would actually have the opposite effect and be driving down the heart rate, be driving down the cardiac output to lower levels. You'd be more likely to see something like bradycardia develop, right? Usually a heart rate less than 60 or so. And notice normally the vagus nerve is mainly going to be innervating the SA and the AV node, right? Mainly the pacemaker cells. So you're going to find that parasympathetic innervation has less effect on like contractility than really the sympathetic nerves do, which makes sense because you can see it directly innervating the ventricles here versus just affecting the actual pacemaker cells. That kind of makes sense. All right. So what you're going to find is that stimulation of the heart has to happen in a very kind of particular manner. Otherwise, you can what do you call it when the electrical activity is all kind of messed up? Yeah, so we call it an arrhythmia, right? So again, you're going to find that essentially, if you screw up the way this electricity is being conducted, you're going to have arrhythmias that can develop. It's no good. So how this normally occurs is that basically you're going to find that the myocardial cells are really well designed in order to allow for action potentials to flow in a basically kind of a one-direction sort of manner generally. And one of the things it does is it has these intercalated discs. Another kind of fun word to say is intercalate. But you have an intercalated disc that basically allows for the action potentials to flow in a particular direction, essentially, right? And one of the other things that helps to prevent kind of the backflow of these action potentials, we're going to find, remember that refractory period we talked about? Keep that in the back of your mind because this is going to come up again. This is what kind of helps to make sure the electricity is only going in one direction, essentially. But basically, you're going to have the SA node is going to be the first thing that generates the action potential. Okay, that's going to be traveling through, and again, the SA node is located where? Yeah, it's going to be located on the right atria, so kind of starting off the electrical potential here. That's going to be traveling down, and that's going to basically, when you start the action potential, it's going to travel and hit the entire atrial, both atrias at the same time, essentially, right? So you're going to find that both atria are basically going off almost simultaneously, causing an atrial systole. Okay, that's the first thing we're going to see there when you're starting off that SA node. Then you're going to find that potential is going to travel down and is going to hit the AV node at this point. Now, one of the things you're going to notice is that the electrical potential is going to be basically going to be traveling down through the AV bundle here, the bundle of His. This is important. You're going to find there's actually kind of a fibrous stretch of tissue here that actually prevents these action potentials from traveling directly from the atria to the ventricles. Because if you were to imagine if you were to have an action potential that starts right here and travels just straight down, is that going to be a very effective way to pump blood? No, because we said, how do we want the ventricles to pump? Well, sure, after the atria for sure, which would happen if we were to start here and just travel straight down. But the ventricles, in order to pump blood out of the aorta, we should start at the bottom, right? So again, it's kind of like squeezing a tube of toothpaste, right? Hopefully none of you are the kind of monsters that squeeze from the very top. My wife does that. It drives me absolutely crazy. No, you got to roll from the bottom, and that we get the maximum amount of toothpaste out. Doesn't get it. However, by squeezing from the bottom, though, you're ensured to get the maximum amount of blood out of that ventricle, okay? So again, that's really important to make sure that we're going to, and you see this, basically when you're finding this, the action potential traveling down, goes to this bundle of His, again, it cannot travel directly from the atria to the ventricles. And actually there's some disease states where that does occur, and that causes arrhythmias, as we'll talk about briefly here. But basically it's going to travel down through these bundle branches. So you kind of notice there's one for the left and one for the right ventricle. And you're then going to go around to the apex, and then you're going to have these Purkinje fibers that travel back up through the ventricle. So you can see that basically as the action potential travels down, it's going to cause squeeze of the ventricles from the bottom and basically travel up, which is good because we want that to go out of the valve, the semilunar valves, which are going to be located towards the top of the heart, right? Make sense? So this is the normal way we want this to occur. And again, that fibrous band of tissue here is what's going to be preventing that that electric potential from going straight from the atria to the ventricles. And then we wouldn't have a very good squeeze on the heart, squeeze on the ventricles there. Okay. Anyone ever heard of Wolff-Parkinson-White? That's one example of a condition where basically you would have, say, a piece of heart tissue that would actually kind of bypass this fibrous tissue here, and that way they can actually have some arrhythmias that can develop from that. I'm not going to go into detail here on the pathophys of that. You'll get that elsewhere. But just know there are conditions where if you were to bypass this fibrous tissue, it can potentially cause arrhythmias to occur, because basically now you have a direct conduit from the atria to the ventricles, and we don't want that. We really want it to be just to this the bundle of his and go through the bundle branches and all that. Okay, makes sense so far? All right. So again, the SA node should be the pacemaker. This is the main thing. It's going to be setting the heart rate for us. Again, it's located in the right atrium. Is usually beating anywhere between 60 to 100 beats per minute, right? I mentioned that can be affected by the parasympathetic nervous system. It can be affected by the sympathetic nervous system, either way, right? So again, usually with the parasympathetic, we're affecting potassium outflow, usually increasing that if you're having increased parasympathetic activation. Usually from the sympathetic side, you're opening up sodium channels, allowing those to flow in to again make the action potential a little bit easier to occur there. And so one of the things you'll note here, if you're looking at the actual resting membrane potential, so imagine here you're going to have one of these pacemaker cells, kind of seeing their action potentials, and then you're going to notice here's a ventricular muscle fiber, right? So here's one of the myocytes. What do you kind of notice the difference between the resting membrane potentials between these two types of cells? One has this one has a much more negative resting membrane potential, so that's good to know. What else? What do you notice about the slopes of these lines here? They're different. You notice the SA nodal fiber here, they kind of has a little bit of a inclination. There's a little bit of a slope there. That's going to be important. We're going to talk about leaky sodium channels, but this is basically what helps us to automatically set a rate for the heart. So it's going to allow us to have a certain number of action potentials to occur per minute. Is based on the fact that these can automatically trigger off action potentials on their own, which is good. We want that. We don't want the ventricular myocytes to just kind of go off whenever they want, because that's when you have things like VFib, VTAC. We don't want that. We want the pacemaker cells to be able to set when we have an action potential, and they are going to be, and again, the SA node is going to be kind of the king there. It's going to be sending down the signals to all the other pacemaker cells, and they are going to be kind of subservient to that, because generally that's going to be the fastest one. The SA node typically has the fastest rate associated with it, usually about 60 to 100. Now, when you get down to the AV node and like say the Purkinje fibers, these can be secondary pacemakers, right? Or you can sometimes have ectopic pacemakers. Sometimes it can develop where anyone know like what I mean by like an ectopic pacemaker? Yeah, basically it's kind of outside of the system. So if you were to have, say, like a set of tissue that somehow either due to like ischemia or something like that develops some kind of pacemaker sort of activity, that could potentially set the rate of the heart if you had some issues going on, predisposing it to arrhythmias there. But basically they're going to have a slower rate, which is why the SA node kind of takes precedent, right? Because it is faster, because it is the one sending all the action potentials initially at a fast rate. These don't really have a chance to kind of take over. However, if I were to say ablate the SA node, I were to get rid of it, I could still have a heartbeat. I would still have an intrinsic heartbeat based on these secondary pacemakers. Usually it's a lot slower, usually around 40 to 60 or so. So you might find someone who'd be kind of bradycardic at baseline versus having something between that 60 to 100. And then if you had a ventricular pace rate, be around 20 to 40. Probably not super sustainable for life purposes, but maybe you can get you a little bit of flow.
So if you did bypass your SA node and your AV node working, would that have a problem like your upper range? Could you get to that high as you normally would?
As far as the upper range of your heart rate, I don't know what the maximal range would be, because you still have the sympathetic innervation that could still cause it. I don't know how high you could drive that. I don't know if I've ever seen any literature out there that says like, okay, this person had their SA node ablated. What is the maximum amount that you could get that person's heart rate up to? I don't know. It's a good question. Maybe there's some papers out there. There's like some random case studies or something, but it doesn't sound like a very ethical study too. I can't like ablate everyone's SA node and see what happens. But yeah, it's a good question. I don't know. But anyway, just know that SA node typically is the fastest. That's what's going to be setting the action potential for the rest of the heart, essentially, or setting the rate for the rest of the heart. Okay, so again, the SA node to AV node is going to be stimulating the atrial contract. Oh, yes, ma'am. You would find, and typically the pacemaker would only be triggered under certain circumstances. So for instance, if it like detected that your heart rate was too low, or if it detected like maybe you went into like an atrial fibrillation or something where it wasn't like really sending a good signal and you weren't getting a good heart rate, it could potentially trigger off, and then it would take over the SA node function essentially and kind of go through the bundle of his at that point. Yes, sir.
There's also different kinds of pacemakers. So you can have
Sure.
an atrial pacemaker and you have an AV pacemaker. So it helps with the principle kind of, physiologic process the patient's going through.
Absolutely, yeah. Or an implanted defibrillator. I mean, there's lots of different rides that are out there, but yeah, essentially we can take over for different aspects of it depending on the pathology there. And again, I'm sure if you talk to like Professor Gerke, he dealt with this quite a bit, I imagine. I'm not sure how much he dealt with pacemakers, but I'm sure he knows quite a bit about it too, so you might be a good person if you had follow-up questions. Not to like punt it off to other people, but again, you always want to use the experts if you can, right? Just like, if you have like a tox thing, like come to me. If you have a peds thing, go to Dr. Nicholson, etc. Anywho. But, right, so main signal is going to be going from the SA node down to the AV node, as we stimulate the atrias to contract at that point, and then the AV node is going to go through the bundle of His. This is when you're going to start to see a stimulation of the ventricles, right? So again, as that travels down, it's going to divide up into the right and the left bundle branch, and then that can then go down to the Purkinje fibers, and that's going to be stimulating the ventricles contract basically from the bottom up, essentially, to get that good kind of efficient contraction there, right? You can kind of see this wave of depolarization that occurs. So you can see how the SA node can actually be the thing that triggers both atria to contract at a similar time, is based on this kind of spreading wave of depolarization. And that can occur because of those intercalated discs that allow for the spread of that action potential very easily between cardiac myocytes, right? Okay. Again, picture kind of showing the same thing. You have this depolarization. Here's when you crosses over the bundle of His, going down through the bundle branches, and it's going to then spread up through each individual ventricle there. Okay. All right. So looking at the action potentials, again, I've been alluding to this. I said we're good to remember this, and this is important. So we're coming back to this. So this is going to be kind of a modified action potential. You're going to find that the heart works a little bit differently than you would see with something like a neuron or something. However, the same basic principles still apply, right? So again, positive coming in is going to do what to the membrane potential? Going to drive it up. It's going to make it more positive, right? If I have positives leaving the cell, make it more negative, right? These same principles are still going to apply here. So it's good to kind of keep that in the back of your mind. But starting off, these are going to be basically just regular myocardial cells, like say you're doing like just a normal ventricular muscle fiber. Notice here, this is going to have a very flat resting membrane potential. That's good because typically it's more negative than what you would see with something like one of the pacemaker cells, like the SA node, the AV node. That's good because you don't want these cells to trigger off an action potential on their own, because if you did that, then you could potentially cause an arrhythmia, right? We don't want our ventricles being the ones that set the rhythm for the heart, because that's usually pretty bad for our patients, right? So we have VFib, VTAC, all of that bad stuff. So we want these to be pretty flat for the most part, and what you're going to see is that normally it's going to be at this phase 4, which is going to be the resting membrane potential. As I mentioned, probably like -90, but that can be affected potentially by things like, the sympathetic nervous system intervening that, putting norepi on there. Can maybe raise it up a little bit, but normally phase 4 is going to be your resting membrane potential, okay? So, and again, as I mentioned, we have an action potential coming from the SA node. This is going to cause a depolarization of the atria, and then from there, the action potential is going to travel to the AV node and then cause that spreading depolarization of the ventricles. So let's get into the details on how this actual action potential is occurring here, what ions are flowing where, etc. So, looks a little busy. That's okay. We're going to go through each of the steps here. So I mentioned phase 4, going to be resting membrane potential. We're going to have more sodium on the outside of the cell, more potassium on the inside. So we know that. That's kind of a baseline from other action potentials we've seen there. Also important here are going to be sodium channels. We're also going to be looking at calcium channels. These are going to be closed at phase 4. Right, so again, this is just a resting period right here, so these are all going to be closed. They're not allowing extra sodium or calcium to come in at this point. Again, remember, calcium is positive, so if that were to come into the cell, that's also going to raise up the membrane potential as well, okay? Also note, you're going to have some of these potassium channels. They're kind of slowly leaking potassium out, but again, this is going to be counteracted by which pump to help maintain that resting membrane potential? Yeah, remember sodium potassium ATPase pump is also going to be helping. And so that's actually really important. We'll talk about those a little bit later, but that's really helpful for maintaining that resting membrane potential. So sodium potassium pump is still here, still working to help maintain that. Okay, so let's go to the next slide. Okay, so again, at this point, let's say, for instance, you have the SA node trigger off and action potential spreading along, going from cell to cell, and eventually it's going to hit this cell that we're talking about here. Now we're going to have phase 0, which is going to be our depolarization. Okay. Depolarization is when you're basically going to have these fast sodium channels that open up. Once they open, sodium is going to flow which direction? Into the myocyte, right? So we're going to have the sodium channels open up. It's going to allow sodium to flow in. Notice here the sodium channels kind of have 3 different states, basically. We're going to have basically the closed kind of resting state. Here's the open state where it's going to be allowing sodium to flow in, and then it has sort of an inactivated state. So even though it's kind of still open from the outside here, you notice it's kind of being blocked off by part of that protein, and that prevents further sodium from coming in. It's not until that this part kind of comes back out and then the sodium channel closes, will it be back in its kind of normal resting configuration. That's important because we talk about things like antiarrhythmics. We get to that in form. You're going to see that we can have drugs that can affect the sodium channel at different places. That can affect different types of arrhythmias. You're going to find that this also is going to be be affecting the refractory period, right? And it's important to maintain a good refractory period within these cells, because otherwise, if they fire off too early, that's going to cause an arrhythmia, so we don't want that. Anyway, so what's occurring here, phase 0, which you notice is a very rapid rise in potential. That's very positive. This is going to be mainly due to the sodium channels opening, okay? Next, we're going to have phase 1, when the sodium channels start to close off at the end of the depolarization, and then calcium opens up as well. Okay, so you think calcium, what is that going to do for us? Is it flowing which direction? Yeah, it's going to be flowing in, because remember, even though calcium, we have a lot of it within the cells, remember, a lot of that's sequestered away. And we'll talk about this again in talking about the muscles later on, and kind of how we cause contraction there, but there's a lot of bleed over here as far as calcium being very important in causing that contraction. Without calcium, you can't have your muscular contraction. So we'll see that when calcium is going to be coming in, it's going to be in a higher concentration on the outside of the cell. Even though we have a lot of it within the sarcoplasmic reticulum, it's just all sequestered away. So still, it's going to be flowing along the concentration gradient coming into the cell at that point. Okay, so it's going to be phase 1. Notice here you're going to have this little kind of dip here that occurs during a phase 1. We're going to see that sodiums are starting to close. Calcium is going to start to open up. Okay. Next, on this phase 2, we have some of these other calcium channels are going to open up. And we also have some fast potassium channels that are closing here. So notice here, as these channels close and you're going to start to have calcium open up, you're going to notice there's kind of a plateau phase that occurs here. Here's another example of looking at the plateau. Basically, even though you have some negative flow of ions out of the cell, by having the calcium open, you're going to have still a good positive flow in. So this is what kind of maintains a nice kind of steady level, kind of a plateau here. And this is important because, again, when you think about the ventricles contracting, you want to just kind of contract and then let go. Not really. You want to kind of have a second to kind of squeeze, and that's where that plateau really comes in. So again, they're squeezing and then releasing. You don't want it to be kind of just like finger snapping. You want it to be squeeze and then let go. A little bit of time there. That kind of makes sense. But during this plateau phase, these calcium coming in is helping to maintain that flow. You're going to find some of these potassium channels start to close at this point, and then we're going to have the repolarization. Right? Repolarization is important because that gets us back to what? The rest membrane potential. This is what's helping to start the resetting process, so that way when another action potential comes along, the ventricle can then squeeze again, right? Or the myocyte can then squeeze again. So again, you're going to have calcium channels starting to close down. We're also going to have some new potassium channels open up, so potassium is now flowing out. Remember, with the positive ions flowing out, it's going to do what to the membrane potential? It's going to go back down because, again, potassium is flowing out of the cell along the concentration gradient. And then we're also going to see the sodium-potassium pump starting to kick up as well, right? So this is going to start during this phase 3, during this repolarization is happening here, okay? And then once we're back at phase 4, calcium, potassium, sodium channels are all closed, and the sodium-potassium pump is really just working to help maintain that resting membrane potential. Make sense so far? So again, biggest things to note here is that depolarization is triggered mainly by sodium coming in, right? The thing that helps maintain that plateau is going to be calcium coming in. And the main thing that's going to cause that repolarization is going to be potassium leaving the cell. Okay? Make sense? And then sodium potassium pump is good for helping to maintain that phase 4, keeping that resting membrane potential at the right level. Those are the big takeaways. Obviously, there's going to be a little bit of bleed over from phase to phase. It's not going to always be that exact. However, those are kind of the big movers and shakers, essentially, right? So if I were to ask you on a test, and I were to say, okay, what ion flowing into the cell causes the depolarization in phase 0, you'd say sodium. Good. All right. So that's important for these fast response cells. These trigger off as soon as the action potential comes along, right? So these are not the same as the pacemaker cells. We're gonna have a slide a little bit later on that shows you kind of what's happening with those pacemaker cells. Okay. Again, just another slide kind of showing the same thing. Here, resting membrane potential, sodium channel opens up. This allows for the phase 0 depolarization to occur. You have some potassium that's flowing out at this point, and then when the sodium channels close, you'll see that kind of that little nick here, that little dip down, and that's mainly due to potassium flowing out of the cell, right? So again, potassium flowing out is going to make it a little more negative. However, when these calcium channels open up, this is where you're going to see that phase 2 plateau, right? This was help kind of lead to that period of contraction, and then once those start to close down, potassium channels open up, the repolarization occurs. And then once they all close back off, now you're back in the resting state. Okay. Remember, sodium potassium pump's kicking in really during phase 3 here, but helps us to maintain that resting membrane potential. Everyone with me? Okay. So you say, okay, what's the point of that calcium coming in? What does that calcium really do for us? We're going to see this is what's going to be really important for causing the actual contraction of the muscle to occur. Which is good because I was like hoping this would be the next slide, and it was the next slide. So that's perfect. I wasn't sure, but. Basically, what you're going to find is that when you have calcium coming into the cell, there's going to be this calcium-triggered calcium release. What the heck does that mean? But basically what you're going to find is that normally when calcium comes into the cell, we're going to find, and this is going to make more sense, we'll talk about this again when we get to actual like skeletal muscle and how that works, but the same process is essentially happening here. We're going to have calcium coming into the cell, and this is what's going to trigger off the sarcoplasmic reticulum. Remember that? Talk about that a little bit. So that sarcoplasmic reticulum is a huge storage space for calcium. That calcium coming into the cell then triggers off calcium, a lot of it, to be released from the sarcoplasmic reticulum, and then that is going to cause the actual contraction of the muscle. Okay. Now, do you want to keep that calcium out forever? No, because you want your heart to relax at some point, right? Because otherwise you're not going to be able to have more blood flow in if it's all contracted all the time. Not good. So when you're ready to have basically the heart to relax, what you're going to find is that the calcium is then going to be shuttled back into the sarcoplasmic reticulum. Keep in mind that this is going against the concentration gradient because you still have a lot of the calcium stored in here. So this is an active process, right? You have ATP causing that calcium to flow in. So you're going to be reestablishing that calcium store within the sarcoplasmic reticulum. And then you're going to find that there's going to be some transporters here. They're going to be useful for helping to get that calcium back out of the cell. One of the things you're going to find is the sodium-potassium pump, as we mentioned, is going to be good at sending sodium out of the cell. This is going to drive, basically, by having a low intracellular sodium concentration, this will drive activity of this cell right here. So not only do you have low sodium levels in here, but you also have high calcium in here as well. So calcium flows out, sodium flows in. This is called a co-transporter, right? We're going to have calcium flow out, sodium comes in, and then the sodium can then be shoveled back out with a sodium-potassium pump. So one of the things, I'll show you a good example of how we can actually affect this process. And again, I hate to turn this into a farm class, but I'll talk about a specific drug that actually can affect it. You can kind of see some of the downstream effects of this. So imagine, for instance, if I have more calcium within the cell, what do you think it's going to do to the strength of that contraction? You think it would increase it, right? Because again, more calcium is coming into the cell. You're going to have more calcium, affecting that sarcoplasmic reticulum. More gets released. More of the actin and the myosin are going to come together. Bigger squeeze, right? And again, one of the big things you're going to find, especially with like congestive heart failure patients, is they have a hard time getting that good squeeze. A lot of times their ejection fraction is pretty low. They're not sending out enough blood, so we want to increase that squeeze in the heart. So what I can actually do is give a drug. Anyone ever heard of digoxin or like Digitec, Digitalis? I can actually find it in certain plants and things like that. But basically, I can give a drug called digoxin. Okay, and the digoxin basically is going to cause the sodium-potassium pump to shut off, right? So by causing that to shut off, we think it's going to do the activity of this transporter here. Well, if I think about this, if I shut this off, sodium levels in the cell are going to go up or down. Because normally the sodium-potassium pump sends sodium outside of the cell against the concentration gradient. So if I stop that, sodium levels in the cell would go up, right? Okay, there we go. So sodium levels are up. This would cause this pump to work less effectively, right? Because again, with having high sodium levels here, this is not an active pump here. Basically, it's just relying on concentration gradients. Because I have high sodium in here, this is going to cause this pump to shut down, basically, to a certain degree. So what do you think it's going to do to intracellular calcium levels? It's going to go up, right? Because I'm not shuttling as much calcium out of the cell. So now I have more calcium in the cell, and we already said more calcium causes a bigger squeeze. So by giving that drug digoxin, by causing the sodium-potassium pump to be shut down, I can increase the amount of calcium in the cell to cause a bigger squeeze and cause an increase in contractility, which another name for that contractility is what? Inotropy, yeah. So again, I would say digoxin is a positive inotrope because it causes a bigger squeeze in the heart. Make sense? So again, just seeing how, and again, you'll run into this when you're looking at like understanding the pathophys, understanding kind of what changes are occurring in these different disease states, and understanding how our treatments are going to modify this. It's good to have a good understanding of the underlying the underlying physiology to see how it works normally, to see how we can modify it. Yes, ma'am.
Is that the same mechanism that dobutamine works on?
Dobutamine is different. That actually is just a beta-1 agonist. That would actually only work through basically the same sympathetic nerve cells to cause an increase in contractility.
So this one specifically acts on calcium channel pumps?
Well, no, because it's actually working on the sodium-potassium pump, right? So it indirectly causes an increase in calcium levels by blocking this pump right here. So again, see, it's kind of like 2 steps removed essentially from what you would think based on the mechanism of the drug itself. So again, these are things we'll talk about and we'll kind of work through when we're getting into some of the cardiac meds in the fall semester. But again, just a little bit of preview, but tries to illustrate to you how we can kind of modify some of these things, what the downstream effects are going to be essentially to cause big changes in contractility of the heart, the speed of the heart, etc. Right? Okay. Turn the mic on. Just FYI, I switched slides 30 and 31. I apologize again. I put it in almost the right spot, but not quite. So I want to talk about these cells real quick before I get to the next slide. So these are going to be what we were talking about before, like things like the ventricular myocytes. Those are what we call the fast response cells. So as soon as an action potential hits them, they're going to trigger off and have their own action potential essentially, right? These are the SA node and the AV node, and other kind of ectopic cell, pacemaker sort of cells are going to be what we call slow response cells. And so there's a little bit difference in how they're working. Essentially, they need to be able to generate their own action potentials. And so what you're going to find is that their ion flow is going to be a little different in several regards. First thing you're going to notice is there's kind of a slope to their phase. Basically, this is phase 4 we're talking about for this when they're at basically kind of the resting period. But you notice there's kind of a slope to it, right? So you're going to have kind of a gradual increase in positivity, and that's going to be due to ion flows of sodium flowing in, essentially, right? So it's called a leaky sodium current. Sodium potassium pump is still working, but basically you're having a little bit of sodium flowing in at a steady rate, and you're going to find this, the potential gets higher and higher and higher till eventually it hits a certain threshold. Okay, that's when it's going to trigger its depolarization. However, instead of sodium being the main thing that flows in at this point, what you're going to find is actually calcium. So calcium is going to be the big thing that flows in, causing the depolarization of the pacemaker cells. Okay, notice there's no plateau phase here. We really just need a quick signal, quick start of the action potential, and then it's going to flow down through all those intercalated discs between cell to cell. We're going to have that spreading wave of depolarization to cause the actual cardiac cycle to occur here. So again, when you get to this phase 2, notice it's not really a phase 1, so to speak. Phase 2 is going to be basically still a little bit of calcium coming in, but mostly it's going to be potassium flowing out. And then phase 3, when you're going to have calcium channels closing, it's all potassium flowing out. And then finally get back down to phase 4 again, where still sodium potassium pumps working, but you're going to have a little bit of still leaky sodium. Yes, ma'am.
Is the leaky sodium the same as the exchange with the calcium, getting the calcium out of the cell?
No, that's different. It's going to be a different process altogether. Yeah. That's really going to be more seen with like the actual, like, you know, the myocytes are really responsible for causing actual squeeze of the heart, essentially, right? It's going to be more important there. Yes, sir.
Yeah, but the leaky sodium current, the pump is still working, but sodium's still kind of like slowly trickling until depolarization.
Yep, yeah, so you're going to find that the sodium potassium pump is still sending sodium out. However, there's other channels that are open. They're going to be permissive of sodium to come in, and that's what's causing that kind of steady rise up. And then once it hits a certain threshold, once you hit that certain period, then it's going to say, okay, let's go ahead and fire off. Let's go and open up those calcium channels. Oftentimes, those are called voltage-gated calcium channels. So once you get to a certain voltage, once you get to a certain level, then that's what's going to cause the calcium channels to open. Calcium flows in along the concentration gradient, and you have that rapid depolarization. Okay. So this is really important because actually, when you're looking at certain ways we can modify this, imagine what would happen if you were to say block the calcium channels here. What do you think that would do to the depolarization? It would slow it down essentially, right? Because again, you're not going to have a complete blockade of that because that would probably kill the patient. But if you were to have a partial blockade there, you can actually slow down that process and actually slow down heart rate. So if you ever hear something called a calcium channel blocker, that's one of the things it can do is actually slow down the calcium influx and slow down the heart rate, right? So these are all like targets for different types of medications we can use to modify how the heart's actually working, right? So here's an example where something like a calcium channel blocker could work, right? So again, these are going to be the slow response cells. These are ones that are going to generate their own action potential. And again, the SA node is always going to be the fastest one. That's when all the other pacemaker cells are kind of subservient to, unless you were to take that out. And then the other ones can then pick up the slack if they needed to, right? Just at a slower rate, essentially. But calcium is a big thing. Here comes the depolarization versus for the fast response cells, all the other cells that are kind of getting a signal from these slow response cells, you're going to find that's mainly going to be sodium causing depolarization there. Okay. So how do we kind of bring it all together? Essentially, we can see like individual action potentials can be represented when we're actually looking at the EKG itself. So you guys are at least familiar with the basics, kind of the basic rhythm of an EKG. So everyone familiar like what a P wave is? What's a P wave? If you don't know, we're going to cover that today, so don't you worry. But yes, we're going to find that you can actually line up all these action potentials and basically get an idea of basically what the heart's doing during this whole process here. So, and again, imagine you were looking at the whole EKG. So this is kind of one cardiac cycle happening right here. So notice kind of the different ways we have here. There's going to be a P, there's a QRS, and then a T. Okay, so it's not like there's clotting factors where it went like 9 back to 12 back to whatever it did. This is all alphabetical, fortunately. I don't know why they started with P. I probably would start with 8, but who knows? Anyway. Someone probably knows that answer, it's just not me. But so anyway, so we're going to have a P wave, QRS, and then a T wave as well. And so I can actually link back what the action potentials are doing and actually kind of slap that onto that rhythm there so we can actually see what's actually going on with the heart. So again, looking at the full cardiac cycle that's happening here. So again, we have the SA node, and remember that's mainly calcium is going to be driving those pacemaker cells that cause the depolarization, and sodium for basically all the other cells that are kind of that are not pacemaker cells. But you can see here is we have the initial SA node, the action potential here, and now you can see the atria. See how they had that sort of fast response sort of cell response right there. Again, this is mainly sodium causing that depolarization. So you can see how this is going to trigger off the atrial muscle. So there, okay, you're going to see the atrial actual depolarization, and you can see this is going to link back up with this P wave here. So when you see a P wave, that's basically going to be the atrial depolarization. Okay. Now, it does not synonymous with atrial contraction. This is what triggers off the atrial contraction, but basically, when you see an atrial depolarization, this is what the EKG is picking up essentially. And we're going to go more in detail on this, but this is kind of the basics of it here. So, okay, so now we have that. Next, after we have the SA node and we have the atria that are going to be depolarizing, what kind of happens next? So the next place to get hit would be the AV node, right? So we go SA to AV, right? So that's the next place we're going to go. And so notice here, this is also going to be a sort of pacemaker sort of cell, right? So again, it's going to have that kind of leaky sodium influx. However, again, when it has an action potential coming along from the SA node, it's going to go ahead and just trigger off its action potential. Because as that potential rises up to a certain level, that's when calcium is going to flow in and then cause the depolarization to occur. Okay, so we have that. Next, we're going to have like the Purkinje fibers are going to be going down. And this is where we're going to start to see the initial depolarization of the ventricles, right? So what you notice here is this is going to line up with our QRS sort of complex here, right? And this QRS is basically where we're going to see the ventricular depolarization. This is what that's going to be kind of being representing right there, right? So again, representing the ventricular depolarization. And then what you notice here is towards the tail end here, you're going to find this is basically you're going to find a wave that occurs with the repolarization. This is actually going to cause the T wave to occur. Okay, so if someone were to ask you what a P wave represents on an EKG, you would say atrial depolarization. We'll say our QRS represents ventricular depolarization, and then a T wave would be repolarization. Okay, so you say, okay, well, I have a ventricular depolarization, repolarization. I have an atrial depolarization. Where's the atrial repolarization? Yeah, basically it gets blocked, it gets covered up essentially in the EKG. Because if you were to look at this, see the repolarization phase here, kind of notice it's occurring almost around the same time as the QRS complex, right? So because of that, it kind of gets covered up, and so you don't see that very frequently. And again, I'm not an absolute EKG master by any means. However, these are just kind of the basics, and we'll get you set up for going into the EKG course later on. But that's kind of the main thing you're going to see there. You don't normally see atrial repolarization because the QRS is covering it up essentially. Because again, that kind of goes back to if you're looking at the amount of muscle mass associated with the atria versus the ventricles are a lot, they're a lot bigger because they got to pump blood out to the rest of the body essentially, right? So again, you're going to find that is a much stronger sort of depolarization, a lot more muscle, a lot more cells are going to be firing off. That's why it's a lot bigger, and it covers up that atrial repolarization essentially. And with me so far? And again, you kind of see back here, if you're looking at ventricular cell that has a depolarization, you can kind of see essentially how this is going to be linked back over to the EKG strip, right? The rhythm strip we're going to see. And so the other thing to note here, I'm going to say like ARP, you remember what that means? It's not AARP, the elderly. It's going to be the absolute refractory period. So we're talking about refractory periods in just a little bit. There's also going to be an RRP, which is going to mean it's going to be a relative refractory period. So we'll talk about those in a little bit, but keep those in mind because, again, this is going to be important when we're talking about like arrhythmias and whatnot. Okay, so talking about the electrocardiogram EKG, or ECG, depending on how you want to refer to it. Most people call it an EKG, I think. So again, this is basically we're kind of recording these electric potentials of the heart. We're not recording individual action potentials, but we're kind of recording the kind of some amount of depolarization and repolarization that's occurring within the heart at a given time, right? And so again, not individual action potentials, but these waves of depolarization and repolarization. Does not talk anything about contraction or relaxation of the muscle itself. It's really just these electrical impulses. Okay, that's really the only thing we're going to be picking up here. Okay, so when you're looking at, you can kind of see here the ventricular action potential occurring here, how it's going to be lining up, say like our QRS complex and whatnot. And again, we're going to talk about things like, different intervals on the EKG to give you clues on kind of what's going on with different aspects of the heart, for instance. So, for instance, you may talk about interval, say like the P to R interval, right? So I kind of tell you the amount of time between, say, the atria contracting to when the actual ventricle contracts. So maybe there's some sort of delay going on, maybe something's slowing down the spread of that action potential, maybe that would be increased, right? One thing you look at. Things like ST segments you're going to be looking at, especially when you're talking about things like ST elevations. If you're talking about like myocardial ischemia, that'll be important when you're talking about that. Frequently, I talk about, from a talk standpoint, we talk about the QRS interval, right? It tells us how long it's actually taking for the actual ventricles to actually contract. And if you slow that down, you can do that in several ways. But I'll show you an example of this in just a little bit later. But these are different intervals you might look at to give you different clues. And the nice thing about a lot of the machines, they'll actually report out the actual interval lengths there. They'll calculate it themselves and kind of tell you what those values are. And you'll kind of learn what the normals are for several things and know when things are abnormal potentially. Okay. So just know when you're dealing with refractory periods, now we mentioned with an absolute refractory period, what does that really mean for us? Yeah, nothing else can trigger that particular cell to have another action potential until it's got to until it's been given a little bit more time to kind of reset itself. That's the absolute refractory period. No strong signal can come along and trigger off another action potential. Conversely, if you're talking about the relative refractory period, what does that mean? Yeah, if you have a really strong, like a stronger than normal stimulus, that could potentially come along and potentially trigger off an action potential. This is really only occurring during this repolarization phase, kind of towards the tail end of that, where you had a strong enough signal, you could then maybe trigger off another action potential. This is important because this is what actually helps to make sure that we don't have, we have normal contraction of the atria and then the ventricles. Because if you can imagine, I'm gonna try drawing this out, see how this works. Probably not well, given my drawing skills. But let's say we were to look at kind of a this is really big. Okay, let's say we had a 4-chambered heart here, the atria, yeah, the ventricles. I'm gonna use something. Use your imagination, please. Okay. So imagine if you were to have your action potential come along. Now notice this will mainly be flowing in this direction, right? And then it'll then come out this way. It's a little arrow, and then it's going to come up this way. So that's mainly the way the main flow is going to happen. So the reason why you don't see that it just doesn't come down and then kind of re-trigger action potentials in here is because those refractory periods, right? You may still have those signals coming along, but because those cells are at a point where they're not reset yet, they're still in their absolute refractory period, they can't be re-triggered at that point, right? So that's why the atria, they'll have that single contraction and then they're done. If you were to have something occur, maybe like some ischemia or something that damages the tissue that screws up that refractory period, that's where you can start to have these arrhythmias that can start to occur. They have this reentrant sort of phenomenon that occurs, and that's where you can have things like AFib and aflutter and whatnot. Again, I'm not going to go a lot into the pathophys here, but just know that this is what kind of prevents these scenarios from occurring, right? When you normally have these refractory periods at a normal sort of interval and a normal sort of length, okay? By shortening or lengthening these in either direction, you can find propensity for arrhythmias to occur. That make sense? So refractory periods are very, very important to make sure that we don't have things like, say, for instance, like, say, premature contractions, right? So premature ventricular contraction or something you may see on EKGs, or basically if we were to have an action potential come along and trigger off too soon, you'd have a heartbeat that would occur before it really was supposed to, and they call that premature ventricular contraction, essentially. And so you can see that, it's like, for instance, right here, it's like an early premature contraction that would occur before, like, the next heartbeat would normally occur based on what their rhythm is, essentially, right? What their rate is. So we mentioned that the P wave is generally going to be atrial depolarization. That P to R interval is essentially where we're going to be actually seeing the atrial systole actually occurring. So that's what's occurring during that phase there. And then the QRS complex, as I mentioned, is ventricular depolarization. The ST segment is also called that plateau phase. Again, let's remember that calcium's coming in to cause that sort of plateau there. And this is where we're actually going to be seeing where the ventricular systole is actually being complete. And then the T wave is generally that repolarization that occurs there, right? So even though we're seeing that normally when you see the repolarization, what's happening to the potential of the cell? It's getting more positive or more negative? Getting more negative, but even though it's getting more negative, you still see it has kind of a positive deflection here. And we're going to talk about why that is as far as like the EKG goes and reading these kind of waves of depolarization. So again, it still looks positive, even though you're really getting the cells are becoming more negative essentially, okay? All right, just another picture kind of showing you how everything's kind of lining up here, showing you kind of different intervals you would normally see. A really big one that I will harp on a lot, especially in pharmacology, is the QT interval. So basically, QT interval, what do you think this is kind of telling us? So the time from the ventricles initially depolarized to what? When they repolarize, right? So if you ever heard of QT interval prolongation, you might hear that with certain medications, especially drug interactions. This is a big one we monitor for with a lot of patients. If you have that elongate, that can affect that refractory period, make it longer in some cases. You may find you may cause yourself to be more likely to have an arrhythmia. Anyone ever heard of torsades or torsades de pointes? That is an arrhythmia that can occur potentially when you have QT prolongation. It's a very potentially life-threatening arrhythmia that can happen there. We'll go into detail on that in pharm for sure. We'll definitely talk about it there. But essentially, these are things we can look at. By looking at different intervals, you can get an idea of what different aberrations are occurring within the heart, right? Okay, so let's talk about our leads here, or EKG leads we're going to be seeing here. Now, normally, we're going to be finding that we'll talk about the different, like, hexaxial leads. We'll talk about the precordial leads and all of that in detail here. We're going to start with kind of the basics and get a little bit more complex as we go along. Because normally when you're looking like an EKG, a big full EKG, how many leads are you looking at? I call it 12 lead EKG. And basically, you're going to be seeing that these are different ways to look at the heart, right? You can basically use, we're talking about the kind of a hypothetical camera that we're going to be using to look in the heart, but by placing leads on different parts of the body, you get an idea of how different aspects of the heart are conducting electricity. You can look for things like, okay, well, is there ischemia occurring? Where is this ischemia occurring at? Is it, which part of the heart is it actually occurring at? We'll show you how we can actually look at that. Now, do I have any EKG experts here? Okay, so you were a tech, right? You did perform the EKGs, correct? Okay, good. So if I say anything wrong, you're going to correct me, right? Fantastic. Okay. I haven't heard a peep from you yet, so that's good. All right. Too much time to say anything stupid. Anyway, so the first thing we'll talk about are going to be our bipolar leads. Doesn't mean they get really depressive and they get really manic. Basically, just means that they're going to be traveling in two different directions, essentially, right? So these are leads with two opposite physical poles. And so if you were to hook this up to the patient, typically what you'd end up seeing is you're going to connect one lead, usually lead 2, over to the right arm. You'd have lead 1 on the left arm here, and then this lead 3 would be on the left foot. Okay. And you're going to notice how we're going to get kind of 3 different pictures here, basically how the heart's going to be conducting electricity. Now, when we're looking at these, essentially, you're going to see that the camera, basically how we're looking at the heart, is going to be from the positive lead looking towards the negative. Okay? So think about the camera. And again, I put a link to a video. It's like a 40-minute video, but I think it does a really good example of kind of describing this stuff as well. So you can look at that YouTube link whenever you're done with this. But basically, again, the positive electrode is going to be the camera looking towards the negative. Okay, so good. Keep that relationship in mind right now. Okay. So when you're looking at your bipolar limb leads, basically it's recording that voltage is occurring between various areas. So for instance, when I'm looking at lead 1, you notice here it's going to be traveling between the right arm and the left arm. So basically, when you're looking at lead 1, I'm looking from the left arm, which is the positive end, be looking back over to the right arm, right? So basically what I can see is the electric potential is kind of happening through this area of the heart right here. So imagine left arm, right arm, I'm looking in this direction. Make sense? And the positive looking towards the negative. That's lead 1 in those cases. Okay. For lead 2 and lead 3, your camera's going to be basically going to be in the left foot. So you're basically going to be getting sort of an inferior look at the heart. But lead 2 in this case is coming from the right arm. Lead 3 is going to be coming from the left arm. Okay. Again, this will give you a little bit different views. That's why the potential, the actual amplitudes of the waves and things like that look different, because again, you're measuring it from different angles essentially. Okay. Makes sense so far? And it's good. So I've asked on a test, for instance, okay, if you're looking at lead 1, what is this measuring the potential between? You can say, okay, well, I know it's going to be between the left arm to the right arm, right? So again, those are things you might want to know because you want to know where these leads are going to know what kind of view you're going to get of the heart. Okay. Next up, we have our unipolar leads. So this one gets a little bit more complicated because at least with the bipolar leads, it was going from, say, one electrode to another. This is a little bit different in the fact that through the power of math and science, we can actually put our negative basically in the heart, essentially. Basically, it's able to do the calculations where it makes the negative electrode basically the center of the heart. Okay. With these leads, we're going to be able to go from individual limbs directly to the heart, and that's going to be our negative, right? So again, in these cases, all of these limbs are going to be the positive, looking towards the heart, which is going to be our negative. Okay, so we're going to get things like the AVR lead, which is going to be basically going from the right arm, looking into the heart. Right, so again, you're going to be getting sort of a look at which side of the heart, basically. Probably the right side, versus when you're looking at something like AVL, so you're going to be looking from the left hand over into the heart. It's going to be able to give you an idea of what's going on the left side of the heart. Right? So we're looking at different angles essentially to see what's going on. So if there's like something going on with, say, like the right atria, I can look at that specifically, say in AVR versus in AVL, and I get a different view of that. Okay. And then AVF is going to where, do you think? Going to your foot, right? So again, it's going to be the left foot in that case. Again, that'd be another sort of like kind of an inferior look at the heart, because again, it's going from the left foot up into the center of the heart essentially. Okay. So these would be the unipolar leads, because again, they're only going from one lead physically on the body into the heart. And then we'll talk about in a second here the precordial leads. These are actually going to be ones we're going to be placing directly on the chest, as we'll see here in just a second. Okay, everyone with me so far? Making sense? Okay. I'm going to actually show you the full EKG. It might make a little bit. But right, so looking at the unipolar leads are reading the voltage from a single electrode on the body back to the center of the heart, and again, the machine's able to do the math for us to kind of figure all that what that should be there. For AVR, it's going from the right arm to the heart. For the left arm, it's going from AVL, it's going from the left arm to the heart. AVF to the left leg, left foot up to the heart essentially. So that's a good way to kind of remember where those are going to. And again, that ethereal negative is going to be right there in the heart. So you're basically looking at the positive is going to be wherever it's actually physically at in the body there. And these are called, in addition to the bipolar leads, these are going to be our hexaxial leads, because they're basically giving us kind of 6 different angles to be looking at the heart. So you get kind of a full kind of planar sort of look at the heart from kind of all angles at that point. Okay. not only from lead 1, but we also have lead 2, lead 3, and these are all different angles we're looking at that. Also AVL, AVR, and AVF. Okay, so here like the hexaxial plane, this is basically what we're referring to are these leads here. Okay, all right. Next, we're going to have some more unipolar leads. These are going to be the precordial leads, and these are ones you're actually going to place on the chest here. And again, I'm not going to get specifics on placement necessarily, but just know that when you see things like V1 through V6, these are ones you're actually going to be placing on the chest. These are going to be the precordial leads. These are going to be able to look specifically at different parts of the heart, especially where do you notice it's kind of focusing on mainly? Which side of the heart? Yeah, looking a lot at the left side. Why do you think we care about the left side of the heart more than the right side? Is it getting short shrift? Yeah, so left ventricle is really good for sending blood to the systemic circulation. So, and if you're looking at the heart, like the left side of the heart is bigger or smaller than the right side? It's bigger, right? Because it needs more muscle to pump that blood all the way through the body. So, what do you think oxygen demand is for that side of the heart? It's a lot higher, right? So again, if I have a lot higher oxygen demand, and let's say I got someone who's got a bunch of plaques developing in their heart, and they start to block up, where do you think it's most likely to affect? What side of the heart? The left side, right? So again, it kind of goes back to thinking, well, if you're going to have a heart attack, most likely it's going to be on the left side of the heart. So we want to be able to look at that in much more detail, right? So again, this would be something like this would be a left-sided EKG, 12-lead EKG. However, could you reverse this? Yeah, you could do a right-sided EKG and potentially reverse the order here, and then you can potentially see from the right side of the heart. This could be more important for someone who has like really significant like right ventricular hypertrophy. Like if you had someone who had like really bad pulmonary backup that causes the right ventricle to get a lot bigger than it normally would be. That could be one case. But in general, I don't know, what would you say, like 99 times out of 100 is going to be a left-sided EKG, right? Only in certain circumstances would you need right-sided. Anyway, that's the basic reasoning there. So here's another good table kind of showing you where all the leads are going to be looking at. Again, I'm not going to focus so much on the precordial leads, on like where specifically you're placing them. I'm not going to ask you which intercostal space does this one go to. That's not really my purpose here, but I do want to have an idea of kind of what each of these are going to be looking at essentially, right? Kind of what areas of the heart it's going to be looking at. So again, the ones on the far left side here, they're going to be looking at more kind of a lateral aspect than it would be, say, if it was looking more, say, right on the front, would be more kind of looking at more of a septal sort of view. And there's an EKG will show you what those look like in a second. So looking here, you can kind of see what a normal 12-lead EKG would sort of look like. Notice here, lead 2 is usually going to be at the bottom. This is where you can kind of get a more consistent sort of rhythm over time. Notice that when you're looking between, say, like lead 1 to AVR to V1, notice here this is all recording the same period of time essentially, right? So that way you're seeing this beat right here is the same as this beat, is the same as this beat, it's the same as this beat, right? So that way you can see, okay, well, something's weird's going on this lead. How does that correlate to some of these other leads here? So I can see what's going on the same exact beat. However, on lead 2 here, this is where you're seeing kind of a constant a period of time, right? Because you want to see whether, you know, they're tachy, they're bradycardic. You want to see if it's a regular rhythm, if it's not. Those are sort of things you're going to be looking at for lead 2. We mentioned lead 2 is going from where to where? Left foot looking up into. It's going to be looking to the right arm, essentially, right? So again, and again, it's not looking directly from the left foot up to the right arm, but it's kind of going through the heart and going out to the right side, right? So that's basically what we're looking at from that standpoint. And you can see how different leads are going to be getting different views of the heart, essentially. So something like V5 and V6. Notice here, they're kind of be focused more laterally. They're going to be able to look to see if you have more of a lateral issue going on here, right? So again, if the blockage or the infarction is happening here, this is where you're going to be able to look for it, essentially, right? Versus something where, say, like V1 and V2, you notice here there's going to be more septal, right? V2 and V4 are going to be more anterior. So just different views we can see. And we're looking at the heart and see where the issues are going to be lying there, right? Or where the issues actually might be in any particular case, okay? Okay, and so if you notice, like looking at the kind of the spreading wave of depolarization, the reason why you have these positive deflections is because that wave, spreading wave of depolarization that's occurring there is coming towards the camera essentially, right? So when you're looking at something like lead 1, where it's going from which direction to which direction? Yeah, it's going basically looking at depolarization from the right arm to the left arm. Notice this is going to be a positive depolarization that happens here. Notice a positive deflection, right? See the same thing when you're looking at, say, AVL. You see a positive deflection that's occurring there because basically the electricity is heading sort of in that direction, right, towards that left arm. However, if you look at, say, like AVR we mentioned is going to be one of those unipolar leads. Is going to be looking towards the heart, the center of the heart, but it's going to be originating where? It'd be in the right arm, essentially, right? Because that AVR is going to be in the right arm. That's a good way to remember it. But looking in that direction, what do you notice about the deflection here? Looks like it's upside down almost. Because again, it's at that point, the electricity is heading away from that camera it looks like it's going negative essentially, right? So again, that's the reason why you may have positive deflections in one lead, but it might be negative in a different lead. It's basically looking at the direction of the electricity, where it's basically heading to essentially. Is that kind of a good description, would you think? You can tell me if I'm wrong. I'm totally fine with that. Fantastic. See, once I get approval, then I can just go ahead and keep running with it and say, well, she told me I was right, so I can say it. Yeah, so this is another good picture kind of showing you. Imagine you had a CT of a patient. You were looking basically at them again. You can see different where the leads are going to be. You can give a better kind of visual representation of kind of what areas of the heart the different leads are going to be looking at essentially, right? And again, with the unipolar leads, the negative is going to be within the heart. However, the bipolar leads is going to be where? Depending on where you're looking at essentially, but usually it's going to be like the right arm, could be the left arm if you're looking at like lead 3 essentially, right? So again, just remember to kind of go back and kind of remember where those leads are going to be originating, where they're kind of looking to essentially, okay? All right. Again, you can link back the EKG to where the heart sounds are going to be. Again, I would employ you to go look back at those earlier pictures where you're looking at like, you know, when the ejection is actually occurring, the pressures and all that kind of stuff. This will show you the same thing here, but basically you'd expect S1 to occur. Right, that systole going to be occurring during which phase of the EKG? So it said during S1, this is where we're going to be having the ventricle squeezing. Which valves are closing to cause the lub? It's going to be the AV valves. Remember, there's going to be the first thing that closes there. It's causing the lub. S1, that's when the ventricles are squeezing. So you'd associate that with which part of the EKG? QRS, right? Because that's when you're seeing the ventricular depolarization actually occur there, right? So you can associate that with the QRS complex versus the dub is when we're actually having the relaxation of the ventricle. This is where we're having the SL valves are closing at this point, right? The aortic and pulmonary valves are closing. And then that's where we're going to see more like your T wave occurring around that areas because that's when you have the repolarization of the ventricles. You're getting reset for the next action potential to come along, okay? All right. And again, you can look to see, you know, going back to that earlier picture, again, it will show you how the ventricle pressures kind of look during different phases of the cardiac cycle here. Again, you can see when you have the depolarization of the actual ventricles, there's kind of a split second later when you actually have the actual squeeze occur. Once that happens, it's going to cause the mitral valves, and the AV valves, mitral and tricuspid valve to close. Those pressures are going to start to increase at that point, right? Remember that, and once it gets to a certain pressure, that's when the SL valves are going to open up and then blood's going to flow into the aorta. Primary is what we're going to be kind of focusing on here, at least. All right. And so you can use the EKG to detect all sorts of different arrhythmias. Obviously, things like, you know, bradyarrhythmias we mentioned are going to be anything below 60 typically. Tachyarrhythmia usually above 100. And again, usually you're looking for certain things in EKGs to detect whether it's a normal rhythm or not. Like, can you see a P wave every single time, right? Can you see that atrial depolarization? You know, looking at things like ST segments, looking at, you know, for instance, I look at a lot at QT prolongation. I look at a lot at QRS prolongation that can tell me if different things are occurring within the heart. I'll show you an example here in just a second. But again, you're going to learn kind of what the normal intervals are going to be. One of the things you'll note though is when you get those 12 leads that come out, they will give you an interpretation essentially, right? And it'll say something like, oh, we think here's a lateral MI, or we'll say something like that. Be careful when looking at those because you don't want to always pigeonhole yourself. I've had cases where an EKG will come back and will report something that seems problematic, but when someone actually like puts their human eyes to it and looks at it and interprets it, it's really not that bad, or it's really going to be something that you need. Make sure you're still using your thinker and not just taking the machine's word for it. Would that also be correct? Yeah, machine can be wrong essentially, right? In a case where you had cases where like, you know, something like a QTC interval looks like really, really prolonged, really concerned about it, and then when actually someone got their calipers out and actually measured it themselves, like, nah, it's not actually that bad, you know. So sometimes it all depends. But always make sure you're always use your brain, right? Never just read the numbers. Okay, so here's an example how I might use it in my clinical, you know, sort of realm in toxicology. So this is where I'm kind of assessing drug exposure in EKGs. So again, as I mentioned, I'm not a particular EKG expert in all things. However, there's certain things that I look for to help me out in trying to assess whether or not someone's had an exposure to a specific type of drug. So for instance, anyone ever heard of like a tricyclic antidepressant? Yeah, Elevil is a really good one. So it's kind of an old school sort of antidepressant drug, very, very dangerous. And actually, one of the things you'll learn is that when people first start antidepressants, they actually have an increased risk of suicidality. So the fact that they were giving these to patients and then increased risk of suicidality, and this drug could very easily kill you, not great, right? We used to have a lot of patients coming in for suicidal attempts on things like Elevil, and a lot of people died from that. And so one of the things they noticed was there's particular EKG changes you can assess with these exposures. So for instance, Elevil or amitriptyline is a particular example where it actually blocks sodium channels on the heart. Okay, we think, okay, block sodium channels. What do you think that would do to these myocytes? What do you think would actually happen? So you think, okay, well, the ventricles are going to be affected. We know that during those fast response cells, what causes the depolarization? It's sodium influx, right? Well, if I block those channels and I prevent sodium influx, what do you think it does to that depolarization? Slows it down, right? So it's going to slow it down by blocking up some of the sodium channels. So we mentioned which set of waves are going to be associated with the ventricular depolarization. I mentioned QRS. So when I block sodium channels in those cases, what I can actually find is slow down that depolarization. I cause my QRS, do you think, get shorter or longer? It gets longer. So I can actually look at the widening of the QRS, and that gets beyond a certain scope. I know, okay, well, this is very abnormal. However, this is something I would expect to see with this type of drug. It's like, okay, well, QRS is prolonged. That is something that's not good because as you prolong that, you can increase the chance for arrhythmias. Not great. Because we almost call it like a pseudo bundle branch block. You'll learn more about that later, but basically that's kind of what it looks like when we're evaluating these EKGs. Other things you can see, tachycardia, because this is actually blocking muscarinic receptors. We mentioned if you were to block those acetylcholine receptors, what does that do to heart rate? Should increase, because normally the parasympathetic innervation there would cause the heart to slow down. By blocking that, though, however, you're going to cause it to speed up. So if we evaluate to say this looks like a tachycardic patient, you would notice that the QRS would be prolonged in these cases. You can kind of notice that, say, for instance, you're looking at lead 2 here, the QRS complex is going to be wider than it would be otherwise. You normally see, like, say, a non-drug exposed sort of patient there. Other things you can see. Certain wave deflections you can actually see in certain leads that kind of clue me in, hey, this looks like it could be one of these sodium channel blocking drugs. It could be something like this. And actually, this an EKG like this would dictate that we need to initiate a certain intervention. We actually do alkalization for that patient, try to make their blood more alkalotic. I'm not going to talk about why now, but just know this would be one of those things where if I saw an EKG that looks like this for this type of patient, and I know they were exposed to this, I'd say, well, they probably need this intervention, and actually can dictate how we treat our patients. So again, EKGs can be very important to lots of different people, but that's how one case where I might use it for tox purposes. So, any questions I can answer? You can go watch that video. I think it's pretty good. I'm not sure who actually made it, if he's a doc or a paramedic or anyone, but it's a very good, succinct video, kind of going through all the differences in the different leads and placement and what it kind of tells you. Any questions I can answer for you in the meantime? Well, enjoy your extra time. I will see you next time.